We're gonna get started, everyone. So hold on a second. Yeah, there we go. All right, I'm gonna let everyone in.
Okay, so when can I start sharing my screen, or we're gonna stay on this screen?
When the video is done, Liz, that's your cue to get started.
All right, thank you.
No, got you, bitch. We are the stars, the bright and morning stars, with the power to be seen across the world. We not the future, we the present. Invest in us and you will see the world is changing. Because our bodies and the future we hold it. We want for you to see that everybody can win. Could it be education or contraception? Everyone will always be here to sing. We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice. We on the ground in every area. We're the ones to make a world a better place. We want the best, we want the way. And there's something for a future so bright. Because our bodies, and the future we holding. We want for you to see that everybody can win. Could it be education or contraception? Girls and boys, we always be fine. We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice.
We gon' climb up and then rise up. Won't keep our eyes shut, we ain't got enough. I know you tired of seeing things the same way, but in time you realize that things change. We the demographic dividend. You see the work that we putting in. I'ma stay true to me and use my opportunity to show you how to build a community with unity.
உன் வாழ்வு உந்தன் கையில், எதிர்காலம் உன் கண் முன்னில், மனதையும் உடலையும் பாதுகாப்பாய். வேண்டும் வேண்டாம் என்று சொல்ல உனக்கு மட்டும் உரிமை உண்டு. தேவையில்லா குழப்பம் நீக்க வெவ்வேறு பல வழிகளும் உண்டு. உதவக்கரங்கள் உண்டு, முன் வந்து சொல்வாய் இன்று. உதவக்கரங்கள் உண்டு, நீ முன் வந்து சொல்வாய் இன்று. இன்றே முடிவு செய், உடல் நலத்தை உயர்த்தி வை. இன்றே முடிவு செய், உடல் நலத்தை நீயும் உயர்த்தி வை. Because our bodies, and the future we hold. We want for you to see that everybody can win. Could it be education or contraception? Girls and boys will always be fine. We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice. We are family and we are planning to go around the world telling everyone that we demand a voice. We
Good morning, good afternoon, good evening. We will be getting started in 1 minute.
Hi, everyone, and welcome. I'm going to just give a few brief remarks before we get into the session. So welcome, everyone, to the Advocacy and Accountability Subcommittee's community session. And we are really excited to be part of the Not Without FP virtual forum. We hope you're staying healthy and well. And my name is Kate Barrett, and I am a program officer with Advanced Family Planning and one of the co-chairs of the International Conference on Family Planning's Advocacy and Accountability Subcommittee. We will soon give an overview of the session and then break into roundtable discussion groups on different topics related to advocacy and accountability. But first, I wanted to give a little background about the subcommittee. We are one of the many subcommittees for ICFP, and the main aim of our subcommittee is to initiate and coordinate efforts to highlight the role of advocacy and accountability during ICFP at the global, regional, national, and subnational levels to ensure access to voluntary quality family planning information, services, and supplies in the context of sexual, reproductive health and rights. We as a subcommittee will reconvene around our specific objectives for the next ICFP after this virtual forum. There might be a slight hiatus as there's ongoing discussions about whether or not to postpone, once again, the next conference. So if you're not already a member of the subcommittee and would like to join, please email me and I'll put my email in the chat. And for those of you who are already members, thank you for your help organizing this session and other sessions, and we will be back in touch soon. And with that, I will turn it over to my colleague, Liz Tully.
Good morning, good afternoon, good evening. Thank you all so much for joining us in this roundtable session. We're really excited for you to be part of all of these conversations that we'll be having. And please, we are here in this space all together. We need about 20 minutes of your time to get you sorted into the topic that most excites you. So please be patient. We are so glad you're here. And I have a few instructions on how we're going to get all set up this today. So before I start into those instructions, I just wanted to say that if you have highlights from this session and you're one of the people who are on social media sharing hashtags, please do use this hashtag that's on the screen, ICFPAA. So we welcome all of those. So now on to how do we get you into the different topics. So we have a number of topics here. We have 12 different topics. Some are duplicate. You'll see that there are duplicate versions of some topics that we thought might be especially popular. And then there are topics that are both facilitated in English, and then there are separate roundtables of that same topic that will be in French. So we hope that all of these different options will suit you. So here is how you select the topic that interests you most. I will walk you through the process, and then I'm going to open up this slide deck to you so that you can make the selection yourself. So everyone's going to need to open up this link when I put it into the chat. So what I'm going to do is ask you to review the topics on slide 3. So we have all of these different topics on the slide 3. And if you were most interested in how can FP programs continue to advocate when COVID is overwhelming everything, you would say, okay, I need to go to slide 9. So I'm going to go to what would be slide 9, and this is considered roundtable 6. So this is going to be a table that you can manually type your name into the box. Each one of these is a cell, it's a table, so you would enter your name, and if every single spot is filled, then you need to find a new topic that you're interested in. So we only have 15 spots in each roundtable. So then you would go back to the main slide here and select something else and enter your name. So once you have selected that roundtable and you've entered your name, you want to note the roundtable number on the slide of the topic that you've selected. So again, if we went back to that COVID roundtable, it would be roundtable 6. So you would put the 6, you would note the 6, and change your name in Zoom. This is so we can hopefully very speedily get you into your breakout room. So what I'm asking you to do is click on your name, click on more, then rename and enter your roundtable number in front of your name. So if I chose roundtable 5, I would rename myself to 5 Liz Tully. And then hold tight while we assign your breakout rooms. And when you get that invitation to join that breakout room, please accept it. Once you are in your roundtable, it might be a few minutes before you get started as other people are getting sent over as well. So please just sit tight. We're asking a lot of patience from all of you, and we appreciate it in advance. But we hope that you'll still have at least 45 minutes, if not longer, in those breakout rooms to have those conversations. So with that, I'm going to open up the slide deck for you, and I will have the instructions on the screen so you can keep coming back. Well, you'll have the instructions in the slide deck itself. So with that, I'm going to enter the URL into the chat. I need everyone to click on it and find where you're interested in and enter your name. If you have questions, please enter them into the chat. I'd be happy to walk you through a particular area of issue if you're confused about anything. And it looks like we have some people figuring it out, so I'm glad to see that. Julia, Bob, that's great. I'm glad to see people are.
And Liz, perhaps the clarification that to not put your roundtable selection in the chat, that it needs to happen in the spreadsheet. I'm starting to see some people add their number in the chat.
Yes. So yes, the chat, you can just change your name. If you go to the list of participants and you find your own name, you should be able to click on your name or hover above your name. And when you see the more option, click rename and add the roundtable number in front of your name. So if you chose roundtable 5, if I would put 5 Liz Tully. And this will help our person who is assigning breakout rooms to very quickly see, okay, move that person to roundtable 5. The topics, Hyatt, let me share this link again. We're asking you to please go into the presentation. Thank you, Kate. The topics are on slide 3 of that presentation that is linked that Kate just sent in the chat. Oh, that was unexpected.
And also just wanted to answer a question about language. So there are several discussions in French that will be exclusively in French. And you'll see once you click on the slide, you will be able to see which ones they are. It is clearly noted.
Thanks for that note, Leah. I've done something that I have never heard of before, and I'm hoping that this helps. There's something about publishing it to the web. I thought it was, but this was an unanticipated issue that I did not know about. So I hope you all are able to still, some of you are able to get in there and sign up. Okay, so Amanda, you want, I see you've put 21. So let me see if I'm able to.
So once you've edited the document and added your name, if you could close out, because of the heavy traffic, some folks are not able to edit it. So again, if you've already selected, if you've already placed your name in a roundtable room and you have updated your Zoom name, please exit out so others can do the same.
So Amanda, okay, so I'm seeing Amanda, you have put a 21. But I'm guessing you're interested in the slide 21. So let me ask you to please change your name to 18. It would be Roundtable 18. And I will put your name in here for you. You're having, so Manjun, you're not able to change your name in Zoom? Okay, so if you click in participants and you hover over your name, you should get the two options. Well, you should get the option to click more, and then you get the option to rename. Once that you've clicked rename, should be able to add that number in front of it. Okay.
I'm supposed to be in the roundtable 3, but I'm in this. How do I get back into my room?
And sorry, who is talking? I'm trying to see.
This is Moses Muwonge.
Okay, give us 1 minute.
Just a friendly reminder, we have one person putting everyone into all of the breakout rooms. So if you do rename yourself with a number and don't immediately get placed, it's just because it's going to take some time. So we really appreciate everyone's patience. Thank you.
Oh, getting up. And I am responding and if you are sending me direct messages, I am going through those and adding you now. It's a little hard to directly message you back. So, and the self-care, Roundtable
traditional method users
is Roundtable 7. Please add 7 in front of your name.
Where is the one with self-care?
The self-care, I'm having a few people messaging me privately about the self-care, and it's a little hard to message back with the amount of messages coming in. So I was just saying, if you've signed up for the self-care, please enter 7 in front of your name. And if you're looking at the topic, the slide is not the same number as your roundtable number. There are 20 roundtables. So if you're looking at 21, slide 21, that would be roundtable number 18. And you are only able to attend one roundtable, so you must select one topic. So Santosh, if you could decide which one you would like. And thank you again for your patience. I know this is, we want to make sure everybody was able to have a voice in selecting what topic they wanted to be included in. So I really appreciate your patience as we work through this. It's not working exactly as we planned, but that's life. And remember, the session, the slide number is not the same as the roundtable number. If you've put that you want to be in 21, I'm assuming that you want to be in roundtable 18 on slide 21. Okay, Teresa. Teresa, I'm adding you to roundtable 6. Please change your name to show that number 6. Okay. It's fun to see some familiar names as I'm entering items in here. Okay. Okay, so anyone who's entering late, I'm going to share a link in the chat. What we're asking you to do, and there are some issues, we're hoping that if you have selected your roundtable, and if your name is showing up, please click out of the Google Slides. We're having, it's an unexpected issue, is that it's overloaded right now. So we're having problems having people be able to access this link and enter their name. So if you're entering late, what we're asking you to do is open that link, go to the 3rd slide. You'll see different topics there. If you're interested in this first one, family planning advocacy in a shifting environment, go to slide 4. That's where you will enter your name and see the roundtable number, which is 1. You would, if you were selecting this table, you would put 1 in front of your name, rename yourself so that we can easily put you into the breakout room. So please go to hover over your name, click more, rename, and then you can see change your name to be that roundtable number first. Okay. There's only one round. You just select one roundtable topic. That's what we have time for. Oof.
Hi there. I made a mistake and ended up in a French session somehow.
Okay. So
14 is in French or English?
roundtable 14.
Sorry, I know you have.
You would want to go to roundtable 13.
Oh, I'm sorry. Do you want me to change my name again?
Yeah, if you don't mind putting your roundtable 13, and I will put.
They were so excited when they had another participant in the French session.
I'm trying to.
There.
Yeah.
Sorry, last thing you need.
No, it's okay. And what's your name? I just want to into this box.
Please, je vais aller à la table ronde numéro 2, mais en tout cas, je n'arrive pas à m'enregistrer. Et les noms et les numéros.
Alain, n'est-ce pas?
Oui, oui.
Oui, Alain,
Oui.
je viens de vous écrire. En fait, moi, j'ai déjà vous inscrit, donc c'est bon. Donc, il faut juste changer votre nom pour ajouter le numéro 2 juste avant, pour que la personne qui fasse tous les tables rondes peut vous mettre dans la bonne discussion.
Pardon, Kate,
Oui, c'est juste que si vous pouvez mettre le numéro 2, si vous pouvez renommer votre nom sur Zoom en mettant le numéro 2 juste avant votre nom.
Ah,
sur Zoom?
moi, j'ai besoin de mettre 11. I have to put 11. Gosh. Okay, got it.
Oh my God.
My
Je ne
fault.
sais
My
pas,
pas,
Kate, je ne sais pas voir où je dois mettre les noms.
Ok, donc c'est pas grave. C'est pas grave. Déjà, vous êtes déjà sur la diapo, donc ça va aller. Je vous ai mis. D'habitude, on a l'option de renommer nous-mêmes sur Zoom. Mais si vous n'arrivez, ça va, en tout cas, on va y arriver. Merci de votre patience. On sait que c'est.
Ok, moi, je vois les noms sur mon nom sur la table ronde 2. Bon, maintenant, je ne sais pas, je fais quoi pour la suite.
Donc, moi, j'essaie de.
Parce que je suis seule sur la table ronde 8.
Oui.
Une seule en français. Je suis obligée ailleurs parce que je suis toute seule. Je pense qu'il n'y aura pas de table ronde avec une personne.
Attendez, Liz, do you want it, or is it possible, Anastasia, to just let everybody self-select at this point?
For those for people that have the ability to do so, they can do so. But for anyone else, Emily will have to manually do it.
Oui. Allez-y.
Alors, je suis inscrite sur la table ronde 11 et 6. Mais je n'ai pas pu mettre le numéro. Est-ce que c'est bon?
Vous êtes sur la table 11, attendez.
11 et 6, Marie-Laure. Vous voyez?
Oui. 11.
C'est bon?
11 là. En fait, c'est une table ronde en anglais, la table ronde 11.
Oui.
Vous parlez plutôt de la diapo numéro 11, c'est ça?
La diapo 15. La diapo 15.
Donc, c'est promouvoir l'autoprise en charge au moyen des politiques de santé.
Diapo 15. Oui, et 6, Marie-Laure. Diapo 15.
Oui, je vous vois.
C'est bon? C'est bon pour moi?
C'est bon. Oui, c'est la seule chose qu'on avait demandé. C'est pas fait. Je ne sais pas si tout le monde arrive à faire ça. C'est juste renommer. Donc, vous voyez votre
Je
nom
n'arrive
sur
pas,
Zoom.
je n'arrive pas à faire ça. Quand
Ok.
je suis repartie, ils m'ont dit close, fermé. Donc, je ne peux pas écrire encore dedans.
Ah non, vous n'êtes pas obligé de réécrire dans le diapo. Donc, on parle maintenant de fonction Zoom. Donc, si vous voyez votre nom sur Zoom, ça, c'est la même question pour Alain, dont je viens de parler. Donc, on a, si on clique sur notre nom, donc pour vous, vous pouvez
Donc, je
cliquer
peux
sur
fermer ici maintenant.
Oui, vous pouvez, c'est bon.
Je peux fermer.
Vous pouvez fermer les slides.
Ouais,
Et ensuite, juste renommer avec le numéro. En fait, pour vous, c'est 8. Donc, si vous pouvez mettre le nom 8 devant votre nom sur Zoom. Donc, ça n'a rien à voir avec les diapos en ce moment. Donc, si vous cliquez sur votre nom, vous avez l'option de vous renommer vous-même. Par exemple, moi, quand je suis...
Ça,
quand
je
j'ai
n'arrive
commencé,
pas.
par exemple,
Je ne comprends pas. Vraiment, je n'arrive pas à faire ce que vous dites là.
D'accord. Il n'y a pas de souci. Il n'y a pas de souci.
Désolée.
Non, non, c'est la première fois qu'on essaie un truc comme ça, donc on sait que c'est pas forcément facile. Donc, mais on va y arriver.
Et quelle est la procédure? Comment on procède pour...
Exactement, c'est la même chose que moi. Je vois les noms, mais je ne sais pas rentrer. Mais les noms, déjà, il est sur la table ronde, la dia de la table ronde, numéro 2.
Malheureusement, il y a que le Zoom ne donne pas l'option à tout le monde de mettre des gens dans les salles. Donc, il faut qu'une seule personne le fait. Donc, ça prend beaucoup de temps. Donc, excusez-nous, parce qu'une seule personne avec plus de 100 personnes, donc c'est pas facile pour nous non plus. Donc, ça, c'est quelque chose de Zoom qui n'est pas très bon. Mais...
Oui, Lise, moi, j'ai un problème parce que je voulais être à la table ronde 8 et non 5.
OK.
Fatimata. 8.
Hey, at this point, to get started, maybe people do. So if they're already closed, they can't select them, but.
Okay.
I don't know.
But I think we should just let them self-select.
Yeah.
But I think Emily has to do that. I'm not sure how that.
No, they can start, the rooms are open.
Okay.
So if you're able to self-select your preferred breakout room, you're welcome to do that. It does sound like some people don't have the latest version of Zoom, which isn't a problem. It just means we'll need for you to wait for Emily, who is the one handling it, to move you into your preferred room. So thank you everyone for your patience.
Thank you everyone. You might have, the translators might be doing this, the interpreter, so I apologize. I'll just say it again. No, but donc si vous avez, maintenant les salles sont ouvertes, donc on vous donne l'option de choisir. Ça dépend aussi de la version Zoom que vous avez. Donc, si vous n'avez pas la version la plus récente, je ne sais pas si vous aurez l'occasion de choisir la salle. Donc, mais maintenant, vous pouvez choisir la bonne salle. Donc, Fatimata, vous venez de parler d'une salle.
Où est-ce qu'on doit cliquer pour aller dans une salle?
Donc, si vous ne voyez pas l'option de sélectionner, c'est-à-dire que vous n'avez pas, ça dépend, mais vous n'avez pas la bonne version, la plus récente version de Zoom. Donc, si c'est le cas, on demande de vous attendre un petit peu pour qu'on puisse vous mettre dans une autre salle. Donc, pour les gens qui ont la possibilité de le faire, on les demande de le faire. Et pour les gens qui n'ont pas, on va vous mettre dans une salle. They normally can just see the wait out rooms, Anastasia, if they're open. He's asking if he can't see that option. Okay.
Yeah, so they would click, so down at the lower Zoom toolbar, they either are going to see the breakout room. It might be under more.
Okay.
And then they click breakout rooms, and then there'll be a white window that pops up, and then they can select to assign themselves to a breakout room.
D'accord. OK. Donc, si vous regardez en bas de vos écrans, d'habitude, il y a peut-être une option avec les 3 points. Voilà, en disant more ou plus, je ne sais pas en français. Et si vous cliquez là-dessus, d'habitude, vous pouvez joindre à une salle. Donc, il y a l'option de join breakout room en anglais. Je ne sais pas si vous avez ça. Si vous ne voyez pas ça, c'est-à-dire que peut-être vous n'avez pas la plus récente version de Zoom. Donc, on demande de vous attendre un petit peu. Okay.
C'est Fatimata, je suis à la 8, c'est ça?
Donc, vous voyez, vous pouvez vous mettre vous-même, Manon, dans la salle. Ça dépend. Donc, est-ce que vous voyez en bas de votre écran l'option avec les 3 points?
Non, justement, je n'ai pas ça.
Ah, d'accord. Vous n'avez pas More? OK.
Non, je n'ai pas More, je n'ai pas les 3 points.
OK.
J'ai les 3 points, mais je ne peux pas choisir. Il me dit enregistrement. J'ai les 3 points. Quand je clique dessus, on me dit enregistrement.
D'accord.
Sur cet ordinateur.
OK. Donc, c'est-à-dire peut-être que vous n'avez pas la version plus récente de Zoom.
Voilà.
Mais ça va, on va y arriver. Fatimata, entre-temps, je sais que...
parce que moi, ma session doit avoir commencé déjà, oui.
Ça, c'est possible. Mais ça va, on va y arriver.
Fatimata à la 8.
Martha, I see your question. If we're now saying people can self-select the breakout room at this point, if you click on more and go to the breakout rooms, you should be able to select the one that you were hoping to attend instead. So I see that we still have we have almost 80 people still waiting here. So if you are having trouble accessing what those breakout rooms and self-selecting, please let us know. But at this point,
or you can even just put the number you want in front of your name on Zoom. So you can just forget the slides. And if you just want to add your number to your Zoom name. So that's the hard part. Donc, you have the ability to rename your
slide. La slide 15, ça correspond à la salle.
Le numéro de slide ne correspond pas forcément à la numéro de salle.
Ok, d'accord. Parce que moi, je suis enregistré la slide 15. Je ne sais pas que ça correspond à quelle salle. Je crois que c'est le truc 11.
15 pour moi, c'est déjà fermé et c'est en anglais sur les tableaux.
Oui, c'est ça, c'est déjà fait. Oui.
Mais ça, c'est en anglais. Vous préférez en français ou en anglais?
Ça ne sera pas traduit en français?
Non. Il y a que anglais et français.
Wow. Il y a 6 tables rondes qui sont en français. Donc, il y a 6. Donc, si vous regardez, on a la moitié sont dans les 2 langues.
Mais j'étais aussi sur la 8 et j'en avais mon nom dessus là-bas.
Fatimata, je vous vois.
C'est ici, c'est pas Fatimata.
Non, je sais, mais je viens de voir le nom de Fatimata maintenant.
Fatimata, je veux être à la 8.
OK.
Fatimata, si, c'est la même. Je veux être à la 8, s'il vous plaît. Merci.
D'accord. Vous pouvez me mettre aussi à la 8 comme c'est en français?
Oui, c'est en français. Emily, I'm sorry
to
do this to you. Can you put Essie, E-S-S-I-E, Marie-Laure, and number 8? Just so we can do that. And Fatimata C as well.
So the fast, I'm seeing a lot of people asking.
Oh, sorry. On va laisser la parole à Lise pour une seconde. Est-ce qu'on peut laisser la parole à Lise pour une seconde, s'il vous plaît?
Oui, vraiment.
Okay, Liz, go ahead.
I was just going to say, if you are, I know there's issues, if you already were assigned to one, that's the default, and now you're not able to self-select. I think the best way to do that is to just change your name to be the number that you would like to be. Just make sure it's changed, and then the person who's assigning breakout rooms can do that at that point and then reassign you. For all others, if you are having trouble self-selecting your breakout room, if you're not able to find where that is, please change your name to the roundtable number you're interested in. Putting it in the chat, there's so many things coming in, it's very hard to keep up with that. So the best thing that you can do is please rename yourself to that number coming first. And I think it's we have the main session here, what's working in family planning and universal health coverage advocacy. This will be in English and have a simultaneous French interpretation. So if that interests you, just that is what will be occurring. Let's just say we kick that off maybe in about 4 minutes. So we have enough time to dig in.
Est-ce que vous pouvez inscrire quelqu'un dans cette table ronde?
Oui, est-ce que vous avez l'option de cliquer sur More ou en plus et choisir vous-même la salle?
Non, ça ne marche pas.
Si vous voulez, pour les francophones, si vous voulez, on peut on peut vous mettre dans une salle française.
Ok, ça marche, pas de problème. Parce qu'il y a une salle où on dit anglais-français. Bon, je ne sais pas.
Ça, c'est la salle principale, là où on est. On va commencer dans 4 minutes. Donc, ça, c'est sur le...
Je peux être là-bas.
OK.
Et comment je fais pour être là-bas maintenant?
On reste ici. En fait, vous ne bougez pas. Ça, c'est en fait, on va commencer dans 4 minutes dans cette salle même.
Ah, je ne change pas de salle. OK, d'accord. Donc, c'est plus simple. OK, c'est plus simple. Super, merci.
Alain, est-ce que vous êtes toujours là? Alain, peut-être il est déjà dans la... OK.
Allô, Kate?
Oui.
Oui, bonjour.
C'est Grace?
Oui, c'est Grace.
Ça va?
Ça va. Au fait, je n'ai pas toujours accédé à ma table ronde numéro 5 sur la redevabilité.
Notre amie Amélie, elle est en train de le faire. Malheureusement, Zoom ne permet qu'une seule personne le fait, de mettre les gens dans les salles. Donc, ça prend du temps pour elle. Donc, la pauvre. Donc,
bon, je vais patienter.
Mais je vois que tu as bien fait avec le 5 devant ton nom. Donc,
devant le nom, oui.
Voilà, parfait.
J'attends.
Merci.
Hello.
Okay.
Oui, Kate, je
ne vous entends pas très bien.
Déranger encore, mais j'ai déjà en face de mon nom, mais je n'accède toujours pas à ça. Oui, Kate.
Désolée, je ne sais pas, ça bug un peu pour moi. Vous disiez, c'est qui?
C'est Alain, Je disais que je suis sur la table ronde 2.
OK.
Et j'ai mis le nom dans le Zoom, le numéro 2. Je ne sais pas accéder à...
OK, c'est Amélie qui va... Si vous avez bien...
Je ne sais pas si elle a même commencé.
Il faut juste attendre une autre minute. Et si vous avez bien mis le 2 devant votre nom sur Zoom, c'est Amélie qui, malheureusement, c'est une seule personne qui peut mettre les gens dans les salles. Donc, c'est pour ça que ça prend un peu de temps. Donc, ne vous inquiétez pas.
OK, on va attendre. OK.
Merci de votre patience.
Ouais.
Okay, so this is last call. If you have messaged me at some point, if some of these later ones I didn't get to, if you message me, I'm thinking Odette, I put you into your roundtable. If you could change your number to that roundtable, this is our last call. We are going to get started we're getting started right now with this last main room topic, which is what's working in family planning and universal healthcare advocacy. So at this point, I'm going to hand it over to Patricia to get us kicked off.
Oh, thank you so much, Liz, and thank you so much, everyone. I will hand it back to Lithia, and then I'll connect with you all a bit later. So thank you. Welcome, Lithia.
Thank you, Patricia. Good morning, afternoon, evening, and welcome to this Advocacy and Accountability Roundtable discussion on what's working in family planning and UHC advocacy. My name is Lethia Bernard, and I lead the UHC Engage project at PAI. Today, I'm joined by my colleague and co-facilitator, Patricia Nudi-Araro, Policy and Advocacy Lead at KMET. As colleagues under the UHC Engage project, we've learned alongside one another what's working for cross-country and cross-regional FP advocates as we navigate together the new national level policies governments around the world are introducing toward universal health coverage, and chart together advocacy entry points to ensure decision makers design policies that advance universal access to family planning. We know these country-specific UHC reforms yield unprecedented opportunities to improve rights-based access to family planning, and we're excited for this open space to share and learn amongst colleagues about family planning advocacy experiences, strategies, and lessons learned, advocating for family planning as a priority as UHC programs and policy reforms evolve at the country level. But before Patricia leads us in discussion, I'm going to review a few housekeeping notes to guide our discussion, which will hopefully keep things running smoothly. The first is that we ask you to please use the hand raise function when you'd like to contribute to the conversation, and that's located at the bottom of the Zoom screen. Please also feel free to use the chat function to engage with one another if you agree or want to build on a point. I will also be monitoring the chat box for questions that participants pose and feeding them up to Patricia as she moderates our conversation. Please also mute your microphone when you're not speaking to reduce the background noise. And in terms of the camera, if it is possible, it'd be great to see everybody's faces so we can interact with one another, but if not, that's also fine. And we ask you please limit your comments to 1 to 2 minutes given our limited time. We're trying to make the most of the conversation and hear as much as we can possibly from everybody else. So in terms of introducing one another to ourselves, we ask you to do so via the chat function. Introduce your name and an organizational affiliation. And we also have a map annotation function. So if you so choose, at the top of the Zoom window, you can click on the view options, click annotate, click on the stamp button and the star, and then you are able to choose your country location on the map. So we have a visual of seeing where we're all hailing from afar. So as we let everyone mark where they're coming from and introduce themselves via the chat, I'll hand over to Patricia to lead us through the discussion this morning.
Thank you so much, Lethia. Thank you, everyone. Today, we just want to have a chat around universal health coverage implementation with a bias towards family planning and what advocacy plans are going on within our different countries. And so given that I'm coming from Kenya, I will begin with briefly in 2 minutes, just letting you know what's going on in Kenya, and then maybe you can think about your different countries and share with us in under 2 minutes, as Lethia said. So Kenya is located in East Africa and has a devolved health unit. So health is both at the national level and at the subnational levels. At the national level, there is the policy function and the governing of the referral facilities, as well as capacity building for the different counties. So in Kenya, health is much devolved. And so our priority during this phase is universal health coverage. And we started by having 4 pilot counties that were just taken through, given some funding to be able to offer universal health coverage to their constituents. And there are a couple of lessons learned, and those are the ones that I want to measure on today. One of it, because health was looked at as an issue of making it free, because out-of-pocket expenditure was not very sustainable. And so most of the counties opted to make it free completely for indigents. But we found that that is not sustainable, and insurance-based model is the most appropriate. There was also a lot of issues around curative, preventive, and promotive, and which one to focus on. The pilot focused a lot on curative. We found that to not work very well, that we needed to at least focus on promotive and preventive healthcare as well, and family planning falls squarely on that. So that was also seen to be a major gap. In our different universal health coverage, we didn't start with an essential benefits package, and that has caught up with time. Although the national one does not have family planning, the counties are beginning to include family planning in their essential benefits package. There was also an issue around commodity security, the fact that commodities are not very readily available. But that was also looked up as something that needed to be worked on, because there was heavy reliance on aid, donor funding, and so there was need to do domestic financing. And that led to Kisumu County, for example, where I come from, developing a costed implementation plan to be able to have an implementation framework that is costed to be able to run family planning issues. We also learned that leadership and governance is a huge factor when it comes to universal health coverage and family planning incorporation. And so that is also something that was flagged as a recommendation, that we look at critically at leadership and governance, governors' manifestos, the president's manifesto, and make sure that health is a critical factor in that. And lastly, the issue of primary healthcare being a pillar of universal health coverage, that we don't need to focus very much on curative, but rather focus on preventive and promotion, and make sure that we have sufficient human resource and also community health investment. So in a snapshot, that is our lessons from Kenya. And at this juncture, I will open it up to anyone who has their lessons learned from their different countries. I see we are from everywhere all over the world. And so if anyone would want to share their individual country experiences, feel free to do that. If there's anything I've left from Kenya and you're from Kenya, you can also chime in so that we begin the discussion from what are some of the lessons learned, what is coming out from the different countries, and what can we both learn from what is happening in the county. So at this point, I will open up the floor to all of us to be able to chime in into the discussion. Thank you.
And just a quick reminder to use the raise hand function. And now I'll be looking through the participant list to see who goes first. If I don't catch you, also please feel free to enter a question into the chat.
Okay, so as we wait for anyone to share their individual country experiences, is there anything from the lessons learned that you can be able to include into these discussions around family planning and universal health coverage? It does not have to be your country experience, but anything that you have seen to have worked in any space or sphere or according to your learnings, so that you may be able to start that discussion from there.
All right, can I jump in and ask a question? Sorry, this is Amanda.
Go ahead, Amanda.
Hi, everyone. I would love to hear from Patricia a little bit more kind of about how things are going in Kisumu and how you see this being able to be scaled up across Kenya.
Okay, thank you so much, Amanda. one of the things that I've seen happen in Kisumu is ownership for health has been really high, especially within the political class. So we have seen the political class investing in making sure that indigents receive care. And so we have a scheme that is known as Marua. Marua, it means this is ours. And technically they have taken 88,000 indigents that are not able to afford insurance to be able to pay insurance for them so that they are able to access care. So there was an assessment that was done, and those were the people that could not pay at all. But we have our National Health Insurance Fund that is also really picking up within the county, because there's a lot of campaign around it for everyone to have insurance. In fact, we passed our Health Act in 2019, and it mandates everyone in Kisumu County to be able to have an insurance. So in the pilot, it was really felt that health needed to be free. So you walk into a facility, you get free services. That did not work really well, because we know when free services are given, someone is paying. And when that someone stops paying, then that is not very sustainable. So Kisumu County is adopting an insurance-based model, and that is able to cater to the people who cannot be able to pay. And then the people who can pay then begin to pay. So what is happening right now in Kisumu is we are developing regulations around the Health Act, because it mandates everyone in Kisumu County to have an insurance, but it doesn't say the how. So we are developing regulations around the essential benefits package, and we are happy to report that family planning is one of the list. It has made it to the list, unlike the national essential benefits package that does not include family planning expressly. And we are hoping that within the different insurance scheme, family planning then becomes a mandatory service that will be given to indigents and also to the different insurance schemes. And there is a lot of talk around how can we then ensure that the quality of services the quality of services are assured, and that everyone who walks into a facility is sure to get the service. So right now we have a costed implementation plan that we are also happy to have partnered with PAI to launch in Kisumu County. That we are now advocating for resources to be able to operationalize, so that we get to a point that we are self-reliant when it comes to family planning. Because in Kenya, family planning commodities have been really a subject of the national government through donor funding. And we want to make sure that as we begin to talk around issues of commodities, issues of services, then we are sure that we can be able to afford this even if we don't get external funding. So in a snapshot, that is where Kisumu County is at. There's so much going on and everything changing every single day. And we are hopeful that with assurance that there is investments and all that, then we will now work on making sure that the quality of services are assured, and that we are strengthening the primary healthcare, because we have also we also realized a huge budget for primary healthcare that was never there previously. And we also managed to get a RAMCA, reproductive health, maternal health funding for the last financial year. So we are pushing this year to have some funding for family planning specifically, and begin to operationalize our very new costed implementation plan for family planning. So in a snapshot, that is what is happening in Kisumu. And I'm happy to take any questions if there's any.
Thanks for sharing, Patricia. Noting a comment from Peter Ngouana, proud of the good work by KMET. Indeed, having one county start and show that UHC with family planning can work will help other counties learn and use the same model, or even an improved one, to better the lives of their people. Fully agree, Peter, and echo the sentiment. Any other observations from anyone, even in terms of what their priorities should be for advocates in this era of UHC? Any kinds of top notes or that folks
Bernard. Unfortunately, I cannot see the icon for raising hand. That is why I'm just popping in. Yeah. Thanks for, allowing me to bring my contribution on board. It's just an inquiry from Patricia, and I'll first go ahead to compliment her work. And really, that is a very great job, and we are happy at least we are getting learnings from that. And my name is Aisha Nansamba. I'm a Ugandan, close to Kenya, and I work with BRAC International. So it is kind of more of a food for thought, and trying to inquire if someone on the around has some details. Most of the times when we are designing, say, preventive health care and then access to family planning, the concentration is too much on the women, and yet in the African setting, we know so much that the patriarchy has dominated, and there is that great influence that comes from patriarchy. So are there any discussions ongoing related to how the gender dynamics will be dealt with to encourage the uptake? Because right now it's, there is that full focus of getting access on board and of quality. So the services will be there, but anything in mind related to how the gender dynamics will be dealt with in particular, how the males get on board to support, the advocacy, and also to increase the uptake, which is the intended, maybe outcome that you're looking at. Thank you.
Thank you so much. And I think I'll throw this back to us. Anyone who has any kind of input around what has been asked, feel free to unmute and go right ahead and share. Hi, everyone. Yeah, so I'll probably go in with my 2 cents. Whether Alicia also has something to add. Peter is also here. You can add something. But I think we cannot ignore the role patriarchy plays in terms of access to services. It's not only enough to have services available at the facility. There is need for us to create demand around those services. And we live in communities where if maybe a man says you are not going to get a family planning method, you will not get the family planning method. So we have to, of course, string men along. And also make sure that we realize that even as we bring men into this discussion, there is the other part of not making it seem as if women need permission to be able to get these services. And so there is a balance that needs to be struck there. And so, for example, in my experience, I've found that community conversations work to be able to just understand why is there so much patriarchy entrenched in our system, what informs it, how can we go about it? Because at the end of the day, when a woman has access to family planning, then it's for the benefit of the entire community. It's not only for the benefit of one woman or one family. When we have manageable families, then it's the ripple effect is that everyone in the society then benefits from that. And so from that angle, it becomes a community issue when patriarchy comes into the way of accessing services. And I think these conversations need to be had, because at times there are comments that are made out of complete ignorance. And I think we then need to ensure that we debunk family planning, the role of men and male involvement in it, and to make sure that our communities really understand what value it is that it adds when women access family planning. Yeah, and I'll pass it back to Lithia. I see Peter has a comment in the comment box. Thank you.
Right, I see Peter saying, I think engaging men under UHC must be prioritized, especially knowing the power and economic dynamics around funding the UHC package. In Kenya, it's around $60 a year, and thus men must be encouraged to pay for their households, even as we push to ensure women are economically empowered and thus not rely on husbands.
I completely agree.
Yes, I also see that our colleague Remy has their hand raised. Remy, go ahead. You may unmute yourself.
Good day, everyone. I really appreciate your comments and all that you have been presenting. My own contribution is just about finding out at the community level their religious perspective about family planning. During my years of working on family planning in some villages where I've worked in Lagos, some rural villages, they prefer child spacing rather than call it family planning because of the misconception. And again, we have to listen to them to make their ideas valuable so that we can be able to access the clients and the clients to be able to access the family planning clinics. Also, I believed in community-based distribution of commodities through the volunteer health workers, more so now that there is lockdown, because most of us working in the rural villages, because of the pandemic and the precautionary methods, we don't want to gather people to talk to them again. So we can make use of the volunteer health workers, and also we can make use of our telephone, texting, the new tools, checking on them where they can get services, or who we can give, just to have the data, like somebody presented. Is it in one of the presentations that says they now have data rather than use the hard copies, so we can have data as well. And I'm also thinking during this time of COVID-19, we can explore the use of media. I used it a lot, especially radio jingles in the language they understand, talking on radios, talking on television, and also advocacy. Advocacy now, things have changed because most government, even at the local, the state and the national level, they're now working from home due to lockdown. But messaging, texting, advocating for changes, advocating for commodities at the community health facilities. Because yesterday I had a lady from Nigeria that it was difficult for her to access family planning, to access family planning, that she went to about 3 health facilities. But, I will say, especially the side of, Southwest, that we have come a long way in family planning. And also family planning education should be geographically, looked into. For example, religion plays a part where some people believe you must have the number of children you have. It's okay, so far you are able to cater for them according to family planning. But in that instance, you can have some part of the region having like maybe 15, 20 children per family or 30, and some just having 2 because of our new, educated young elites. So those are just my few contributions. Thank you so much.
Thank you so much, Remy. Those are really valuable points, and I agree with you on certain things you mentioned around language, using language that is sensitive to the communities that we serve, among the other great points that you mentioned. Thank you so much for that. And I think we have hoped towards now the strategies of improving access to family planning within UHC. So maybe we could just go on with the strategies. What do you think works? And how can we then implement it in our different day-to-day work? So the floor is open.
And feel free to unmute yourself directly and to speak.
Are you talking to all of us or to Remy?
Sorry, may you repeat?
Oh, come again. I didn't hear the last statement.
I was saying, please feel free to unmute yourself directly. Patricia was prompting a question about strategies, advocacy strategies in this era of UHC, and you know, any sort of lessons learned or insight that we've gathered over the years that we can employ together as we're advancing the various considerations that our colleagues have already highlighted as community level programs and policies are being designed. What do we know now that we can carry forward with us in this journey?
We have to learn what the people have been doing. And I'm sure, you know, it's acceptable in all countries as well. Before the modern method of family planning, people have their own methods of preventing pregnancies or of, you know, child spacing, so to say, in some other communities. So we have to learn from them again about that and to let them know that these new methods, research has really gone on it and they are been proven to be effective. And we have to dispel rumors. That is very, very important surrounding family planning. And also, I feel it must start not when one is married, from the adolescent. Only we have to know how to package the information, education to maybe adolescent girls, even the boys as well. And how to, you know, now that the pandemic, sorry, is very much around, we can't do under the tree meetings much again. But then observing protocols, we can send messages via text messaging by telephone that they are used to and their favorite channels. There are some local channels that, you know, people in the rural area, for example, listen more to radio. So we can reach them through the radios as well and get the people themselves involved, like training family planning advocates, family planning volunteers. Their jobs may be different. They can still see each other one-on-one, you know, observing all measures, you know, 6 feet apart, putting on mask and all that. And with what I learned from my daughter as well, because age is advancing on me now too, I'm 68, is that, you know, most policy works is now done via internet, maybe Zoom and all that. We can still employ that more until we're a bit free to kind of now wanting to come together, because we have to admit that this pandemic has really affected all of us. And during the course of the study, of the presentation, we were told how the percentage of the unmet needs has widened during this COVID pandemic. And also, we have to work with the local chemists, because this is where the people go first, to train them. You know, some of them, we cannot close their shops just like that. They're working with the government, especially the Ministry of Health. I think we can work with the chemists, because in Nigeria, we have access to chemists. Within 5 houses or 10 houses, you see, a chemist there. One way or the other, it helps. It's when I got to a regulated place that I know some, maybe too regulated systems sometimes affects people's health. That's my observation. You have to go to the clinic, the drug has to be ordered by the doctor, but the whole essence of primary health care is for people to take responsibility for their own health. So some of these, maybe pills, the softer family planning devices, maybe we now train the chemist very well on how to do this. So and male involvement is very important. That is not just for the wife, but both of them coming together. Is not only on commodities, it's about fertility as well. It's about family, planning. I mean, not only for the choices. I mean, for the devices they are taking, but how to plan their life. We have to stress the usefulness of family planning, that it's kind of a lifelong process, whereby when they have their children at the choice time, are they, spaced. They can plan for the schooling, they can plan, for their university, they can plan so that most of this violence we are having among youths now will be greatly reduced, because we've had so many young youths, So that's my humble contribution. Thank you so much for giving me the opportunity.
Thank you, Remy. You raise a very good point, and what has stuck out is how you have kept on mentioning the issue of young people and access. We know that there are really, truly many barriers to access family planning among the young people. And thank you for the insight that you bring to this debate. Anyone else who has any strategies around access, any question up to this point that you might want clarification on, so that we may be able to move with it. So anyone? You can just raise your hand or feel free to just unmute. Oh, thanks.
Patricia, in case no one else is coming in, for me, my icon for raising the hand failed to pop up. Sorry. Yeah, I think for me, I'll be speaking more of the policy-related issue. You spoke about, how can we move the agenda forward and what has really worked. When it comes to policy at most is driven by data. So there should be documentation of evidence. So we should look at, always bringing the evidence on board. It informs the policymaker, though much as, the art of politics also comes into play. We must understand what do the politicians really want for the community, at the same time, listen to what the communities, and then we are able to balance between, the needs, because there are times when these two are not balancing. The community is asking for something, the political agenda is different. So, we always have to bring data into play to inform policy. And speaking again of policy, engagement is very paramount. This engagement should not be at the end when we are disseminating, say, results, but it should start from the point of designing a concept note, such that you walk the talks together and make sure that you're addressing, a vital policy-related issue, which the policymaker will be at the end of the day be accountable to the people, that at least we address this policy in line to the current policy, or the policy was revised in terms of what we are having currently, but not simply to pop up. Then the last one will echo on what Remy spoke about, trying to understand the communities. Let's, the culture, norms, those are things which play a critical role, but most of the times we want to say, this is what is good for you. But there are those norms which have been in play, and they are strongholds, strong believers who think that this is what is working. So we must always understand how do we penetrate through those culture norms. And lastly, when you speak of the young people, this particular category also has its own dynamics. We always tend that to categorize them as one, but we have the young adults, and then the other ones are called them the adolescents. So these are the 10 up to 14 is a very critical age, which we don't have much information about. Some of us think they are too young, yet in reality, when you go on the ground, they are no longer young. Some of them in fragile countries where I have worked, they are already, you know, exposed, they are already engaging in sex, but they are so naive about whatever goes on. So I think those are the dynamics which programming should look into to make sure that the needs of the certain groups and categories are really addressed as needed. Thank you.
Thank you so much, Aisha. You raise very brilliant points around how policy needs to be driven, community engagement and meaningful engagement at that point, not at the tail end, but throughout the process, even before it begins at the programming stage, which really is an interesting insight, and also the involvement of young people into this debate and not clumping them as one that have homogeneous needs, because they have needs that vary quite a bit. Thank you so much for that. Anyone else who has some insights, just feel free to unmute and go right ahead. Okay, if you're having a problem unmuting, I see someone has unmuted. Go right ahead, thank you.
Also, just to buttress what the last speaker said, which is quite right on policy, affecting policy. I remembered working in a rural local government area in Lagos State. After observing the women, I saw that a lot of them were not working, and it was a fishing community. They were not farming because of the saltiness of the soil, and things were really bad. So after my observation at the village, I wrote a compelling memo to the chairman, and I sought audience with him, the chairman of the local government. So when I met with the local government chairman, he told me that when the money comes from the national, that, you know, there is a bit of delay, but he will let me know when the money comes, you know, what they will do. That he had what my organization, Community Health Information Education Forum, chief in short, chief said, and true to his words, you know, when the money came, he bought for the fishermen outboard engines, for the women, sewing machines, but and so many other things that could propel their income generating activities. And like the last speaker rightly said, we must know what the people want, because sometimes when you give things like that are free, some may sell it again, because in the community, I saw their priority. They catch fish, they prefer to sell it in the city while their children are malnourished. So the orientation has to change a bit, working with the people from what they know, from what is unknown to what should be known. So, you know, let the suggestion come from them. At least we have some positive deviants that amidst, you know, challenges, they are thriving, they are doing well. So that's just my contribution. Policy is very, very vital. And also the training of the family planning providers, who are sometimes health workers, because there is no program my organization then organizes that we don't involve the health workers. You have to bring them abreast of what is happening, currently happening, because some of them are working in the rural villages. So either through maybe Zooming now to let them know, like programs like we are on now, this ICFP, how they can, you know, that's what I do now on my Facebook page. I posted it there so that whoever reads it might join the conference So things like that. Thank you.
Thank you so much, Remy. Those are really vital points on the need to engage community. I think throughout these discussions, we've seen the need to engage communities, because you can push a service to them, but if they don't buy into your service, then you will end up with services in a healthcare facility that people don't get to access. So thank you so much, Remy. I will hand it back to Lithia because our time is far much spent. I see a couple of messages in the chat. We could go through that and see if we have enough time for more comments. If we don't, then thank you so much for your contribution. So back to you, Lithia.
Thank you, Patricia. I believe our session is going to close on us in 1 minute. So just to say thank you, everybody, for your patience and your contributions. One of the things that that I'm struck by is that across comments and observations, there's this thread of truly listening and understanding the different needs of the audiences, whether it's the community or the policymakers or the multifaceted, members that make up who we sometimes refer to as an umbrella term, the youth. All of that is incredibly important in the makeup and in the intentional efforts behind policy design, program design, and as advocates using our force, our sort of strength to leverage all of those voices as we advocate for UHC or family planning priorities in this era of UHC. So, of course, just the beginning of a longer term conversation, but really appreciate our colleagues sharing their insights with us this morning and looking forward to continuing the conversation. And very special thanks to Patricia for guiding us through the conversation.
And I just wanted to close because I know a lot of people are coming in from your breakout rooms, and I just wanted to thank all of you for your patience. It just goes to show no matter how much planning goes into it, things can just go awry, and I really appreciate everyone just being loose, and I hope you all had great conversations. So thank you again for joining us today, and I hope you have a wonderful rest of your day. So thanks.
Thank you. Merci à notre groupe.
Thank you. Bye.
Power to be seen across the world. We're not the future, we're the present. Invest in us and you will see the world is changing.
Because our bodies and the future we hold it. We want for you to see that everybody can win. Could it be education or contraception?
better place. We want the best, we want the worst.